recording, and I'm going to turn it over to Mike.
Thanks, Ryan. Again, everyone, my name is Mike Martinelli, Head of Government here at Standard Care, and I'll be presenting today. Let me just pull it up first. Here it is. Can everyone see the PowerPoint presentation?
Good to go, Mike.
Perfect. All right. So today I'll be presenting, as Ryan said, I'll be discussing HIPAA, but I'll be starting off with an intro into like what health data is, how it's designed statutorily, the general overarching definition, and then what electronic media is. And as you can see here, I have a outline of this presentation and for the next presentation, because the next one, like Ryan mentioned previously, it plays off of this presentation as well, because it has to do with different ways that health information is legally defined under certain regulations. And that's important because when you're determining a strategy of how to set up and manage your firm and conduct certain business operations, based on what if it's health data, you have to know which definition it falls into, if any, so you would know which regulations you'll be subject to. So today, I'll start off with the overall definition, the overall arching definition of health information. Then I'll get into HIPAA. And then part two we'll have, that'll be in January, the health breach notification rule, and then information blocking. So what exactly constitutes health information, and how is this relevant to digital health firms? So again, I kind of mentioned this already. It's relevant because when you're dealing with health information, you have to know what exactly it is, like which definition, if it does align with the definition, which federal regulation it would fall under. And the reason that's important, because you need to know whether or not you're subject to these federal regulations. And this is just a graphic I included to show how complex the whole healthcare system is as it pertains to dealing with healthcare data. There you can see in this little central red blob here, we have the data definitions, and that kind of goes along with regulations and regulatory requirements. So we need to know the definitions of the health data or the health information, specifically as they relate to specific statutes. And then once we know that, we need to know which definition of health information pertains to which regulation. So this is health information in general, and this is actually in the beginning of the regulatory text for HIPAA, but this applies generally. We'll see in the next lecture series that health information, the general definition of health information for FTC's health breach notification rule, it's uses the same general definition, but it carves out its own type of definition for the exact type of health information it regulates. So here, health information in general is created or received by a healthcare provider. So you go to your physician's office. They either receive health information from a previous provider that you had or another specialist, or they create it by coming up with a diagnosis, treatment plan. That's health information. And that also includes life insurance, because you need to have a physical, which is health information many times to obtain a life insurance policy. Health plans, those are payers, and that also includes government-sponsored health payers too, because you have the coding for diagnostic procedures and diagnoses. So that in and of itself is health information. And then two, specifically, this really gets specific to what it is it's the physical or mental condition of a person. And then it's also includes the actual the act of providing healthcare to an individual, regardless of whether it's past, present, or future. And then also, because of, I mentioned before, billing involves diagnostic codes and codes for diagnoses and treatments. The payment and provision of healthcare is also health information. So, as some of you may or may not know, the healthcare system, the U.S. Department of Health and Human Services overall. So this is, so for HIPAA, I'll just take a step back. HIPAA is enforced by OCR. That's just an office within HHS, the U.S. Department of Health and Human Services. That department is one of the largest cabinet departments in the United States government in terms of personnel and funding. It's a massive department. And because of that, there's a ton of regulations that relate to health, whether it's health data, FDA is also under HHS. So as if healthcare regulations weren't already complicated enough, now for our purposes, we talked about what health information is in general. Now we have to add that extra layer on top of it, which is the general definition of electronic media, because of course this is specific to digital health. So what constitutes electronic media? And again, this is just electronic media in general. This isn't electronic media as it specifically pertains to health information. So if you have something that's stored on a hard drive, it's electronic material, Word documents, media files such as like music, videos, and they're originally produced in electronic form, typed up on on Microsoft Word or Pages for Apple, or they're of course videos and audio are recorded electronically, so they're originally in electronic format when they're produced, and then they're stored on a digital storage device, so your computer hard drive. And that also includes external hard drives as well, like flash drives. And that becomes relevant to the second part, which is transmission media. So there's two ways you can transmit media, electronic media. First, you could do it physically. So you have a file saved on your computer, you move it onto a flash drive, and then physically move it to another computer and download it to that computer. That's transmitting digital media. The other way to do it is what occurs most frequently, most commonly, is via the internet. You email, an attachment, a PDF file to someone. That's transmitting digital media. So there is an important point here at the bottom in red. One thing, you have to be careful when we're talking about electronic media, because if the media did not originate, if it didn't originate in electronic form when it was transmitted, it's not considered a transmission of electronic media. So an example of that would be if you had say you had a notebook with some notes on them for a meeting, and then you type them up onto Microsoft Word. That way you digitized it, you made it you put it in digital media format, and then you transmitted it by sending it in an email. That wouldn't be a transmission of electronic media, because the original version of it was on a piece of paper. So the important part here is that it has to originate in electronic form. So now that we have the background on health information and electronic media, we're going to hop into the HIPAA privacy and security rules, which are enforced by the Office of Civil Rights within HHS. So first, I'm going to discuss who exactly is regulated under HIPAA, because this is important. You need to know whether or not you're regulated under HIPAA in order to know whether or not you are subject to, their penalties for violating their statutory regulation, their statutes and regulatory provisions. So the main one here is called a covered entity, and I'll be referring to it as CE. That's the common abbreviation. And these are entities that are classified under one of three categories. The two are the most common ones that you likely see: healthcare provider, doctors, clinicians, psychologists, etc. Two, health plans, health insurance companies, HMOs, and then government payers like the VA, Medicare, Medicaid. Again, health plans, that involves the payment for healthcare services. So it comes back to the coding for diagnoses and procedures. And third is healthcare clearinghouse, which is somewhat of a catch-all. These entities process non-standard health information that they receive from another entity, and then they standardize it. And this will become more relevant, and you'll see how this works when we get to the next type of regulated entity, which is a business associate. They are entities that would most likely fall under this category. An important point here at the bottom: healthcare providers are only regulated CEs if they transmit information in electronic form in connection with a transaction for healthcare services. So that's like the caveat for part one, or the first prong here. There has to be a transmission of electronic health information in connection with the transaction or a payment for the services provided. And that's what gives us the federal jurisdictional hook right there. That is what enables the federal government via the U.S. Department of Health and Human Services to have jurisdictional enforcement over HIPAA. And the next type of regulated entity we have here is called a business associate. And these are entities that perform certain functions for a covered entity that requires that the covered entity disclose and use PHI. So an example, a basic example of this would be a small physician practice. They don't have they don't have a lot of staff. They don't have a billing department, so they need to contract out a private firm to take care of their billing. So that firm that takes care of the billing for that small practice would be a business associate, because it would require the covered entity, which would be that physician practice, to disclose PHI to that billing firm in order for that billing firm to carry out their function of taking care of the billing for that practice. And disclosure of PHI in that case would be the coding for the procedures and or diagnoses of the patients. And in purple here, I show how these relationships could, seem a little weird, but at the end, when I kind of wrap up this whole slide, you'll see that there's an easy way to figure out the relationships of who's a CE and who's a BA. So you'll first see here that I said a covered entity can be the business associate of another covered entity. So if there is one covered entity, you have again, we could start with a small physician practice. It's just a family practice, family medicine practice. And they don't have certain diagnostic equipment for, let's say, for imaging. So they need to contract out or make a relationship with a specialist group who can interpret imaging for that, which would be a radiology group. The radiology group alone doing their own practice, they would be a covered entity. But if they're doing a service on behalf of the general family practice, in which that practice sends over imaging to the radiology group in order for them to interpret it, give their expert opinion on what the diagnosis is. In that situation, the radiology group, even though alone they're a covered entity in their normal function, they would be a business associate with the covered entity of the general private practice. And then the second one here is a business associate can be the business associate of another business associate, which also sounds very confusing as well. But just think about it like this. You have a covered entity with a business associate. Let's use a first example. The a practice needs a firm to contract out to do their billing. The billing firm, let's say, they need to contract out another service, let's say accounting. I don't know if that's what they would need, but just say that the business associate that's doing the billing for the covered entity needs to contract out someone to do a function on behalf of them acting as a business associate. That would be, you would think about that as a subcontractor relationship. And that's why I added this graphic here. So you could just look at, so covered entity right here, and then you have a business associate one, and then the subcontractor of that business associate would be that relationship that I'm highlighting right here. And so while this may still seem confusing, what I have down here in the red, this is the easy trick to figure out what the relationship is. Follow the PHI, follow the flow of the PHI. So wherever the PHI originates, so you have a covered entity and they're disclosing PHI to another entity, which would be a business associate, and that business associate is receiving the PHI, that shows the relationship. The disclosing party is the covered entity, receiving party is the business associate. And then if you have that second scenario where you have another business associate, it would just be a subcontractor relationship. So just look at just follow the flow of the PHI. Who's ever disclosing it is the original covered entity. Who's ever receiving it is the business associate. So whenever you have a business associate working with a covered entity, this is required under HIPAA. You have to enter into what's known as business associate agreement, a BAA, and it's a contract. And it stipulates there's certain requirements that have to be included in that contract. The first is the scope of the PHI that's being disclosed to the business associate. This comes back to what's known as the minimum necessary requirement. So the covered entity can only disclose the minimum amount of PHI necessary for the business associate to fulfill and to carry out the function that this covered entity needs them to. And the reason for that is to security purposes. You don't want to give them too much protected health information, because if there's a breach or something, you're releasing unnecessary PHI that didn't have to be in the possession of the BA to begin with. Second, the business associate agreement has to specify the functions. It has to indicate specifically the functions that the business associate is performing for the covered entity by which it's using its PHI. So what functions require the business associate to use the PHI, and that has to be laid out specifically. And finally, it has to set a duration, a timeline. So there has to be a start date for the relationship, and there has to be either an end date or a terminating event. Say the business associate completes the job that the CE needed them to, and they would specify that. And once that job is complete, that business associate agreement is no longer active, and that relationship doesn't exist anymore. And it's important to note that whenever you have a business associate working with a covered entity, they are just as equally liable under HIPAA as are covered entities. So the business associates, they have protected health information, so they're subject to the same regulations as a covered entity as it pertains to the PHI that they hold. So now I'll get into the specific definition of health information as it pertains to HIPAA. So I've been using this term already, but HIPAA uses the term protected health information, PHI. And this is a variation of that general definition I started off with in this lecture. So the basic general definition, and this gets a little bit more technical, which I'll explain, is that it's health information, which I defined in the beginning of the lecture, but that it's individually identifiable. That's important, and I'll get into that in the next few slides. But first, I want to let you know what's included and then what's excluded. So what's included in the definition of PHI is that health information that's transmitted or maintained in electronic media. And then this also includes that health information that's maintained in any other form or medium. So what this is saying is PHI could either be on paper, on a physical thing like a X-ray image, or it could be electronic, like on an electronic health record. What's not included, though, is education records that are covered by FERPA. FERPA is the Family Educational Rights and Privacy Act. And this is kind of important because universities have student health departments and counseling services where students can go to receive treatment. And this also pertains to, you see this a lot. I saw this a lot at OCR, where going to counseling services and receiving treatment there, there's an issue of whether or not the information from that student counseling was health information protected by HIPAA, but it's not, because it's obtained in the academic institutional setting and is part of their education record. Also, this is more common if a student has a learning disability, they require special accommodations. All universities require that student's physician submit medical records or documentation confirming that they have that diagnosis. So once that piece of information, which when the physician has it, it's PHI, but once it's given to the institution and placed in their educational academic record, it's no longer PHI, and it's in the educational record protected only by FERPA. The next one is employment records held by a covered entity as its employer. Easy example is a hospital employee has workers' comp. There's some workers' comp information there, and that includes, a diagnosis and treatment for whatever injury they had. That wouldn't be protected health information because that would be part of their employment record. And then the last is if a person is deceased for more than 50 years, whatever they had that was PHI is no longer considered PHI. So here I have a graphic of, I thought this is important, but this graphic requires the right context to understand fully what PHI is. So if you notice all the things listed here, you don't see anything that says that's health information. You don't see like diagnoses or anything. This is the second part, the second prong of the PHI definition that makes health information PHI. So you have health information, which we defined already, but that health information has to be accompanied with individually identifiable information. And that's what this is in this graphic. So for example, if you have let's say we have an X-ray image of someone's broken, a foot or whatever. Yeah, that's health information. It was produced in the healthcare setting, and say it has the patient's name that's identifiable and date of birth on the top of the X-ray. That would be PHI, because you can identify, you have the health information and you could see who it belongs to. However, if that individually identifiable information was redacted from that X-ray image, it would no longer be PHI, because what makes it protected health information is that the health information can be traced to who it belongs to. That's the important point there. So the general rule under the HIPAA privacy and security rules is that people must grant consent for the use and disclosure of their PHI. So there's 3 exemptions to this. And the 2 are pretty obvious ones and pretty common ones. Patient treatment. So when you go to your physician and you receive treatment, if you go there for the first time, you sign your HIPAA release, giving them consent, and you go there, receive treatment, and they need to send out some lab results to a specialist to get another look at it for analysis, in order to come up with a diagnosis. That's protected health information, but the physician who obtained those labs doesn't need to obtain the patient's consent in order to send it out to a specialist for further analysis, because it's part of the whole process of carrying out patient treatment. It would also be logistically just infeasible. Same with 2, billing and payment. Every time you receive treatment for whatever it may be, there's a billing aspect involved, and the billing has diagnostic codes and procedure codes in it. They don't have to obtain consent for billing and payment operations, because again, that would be overly burdensome and logistically impossible. Healthcare operations, on the other hand, that's somewhat of a catch-all, but you would see this also in the context of BAs, business associates. So if you think about that example with the private general family practice, the small family practice that I used earlier, who doesn't have a billing department, and they have to contract out a billing firm to take care of the payments. They enter into a business associate agreement with them, and they disclose only the PHI necessary for the billing firm to carry out the billing procedures. When that's the case, the hospital does not need the patient's, or the private practice does not need the patient's consent to disclose their health information, their PHI, to that billing firm, because that is happening. That is a part of the process of carrying out healthcare operations. Stop and I see if anyone has any questions here in the chat. So far, all right. So now I'll get into the privacy rule. I talk about both the privacy rule and the security rule. I just briefly go over the privacy rule because it's not as relevant to digital health, but it's important for the whole context. So the privacy rule, the main purpose of this is to address the confidentiality regarding an individual's PHI. And this is accomplished through their regulations that are designed to prevent unauthorized parties from having the ability to associate health information with a specific individual to which it belongs. Right there, that last part of the sentence, that is what the definition of PHI is. If you have health information, but there's no individually identifiable information on it, then you can't determine to whom it belongs. So it doesn't constitute PHI. So takeaway here, primary objective of the privacy rule is to protect the confidentiality of PHI. Now for the security rule. This addresses the maintenance, transmission, storage, use of ePHI, and E is electronic PHI. So this is where we're merging electronic media, that definition, with protected health information. So the security rule sets a series of minimum, what we call implementation requirements and standards, to which covered entities and business associates must adhere when they store, maintain, access, transmit, use electronic PHI. And its primary objective is to protect the confidentiality of ePHI, electronic PHI. So that is done with setting some security, like suggestions. So what the thing about the security rule is, because it deals with technology, is they set series of, I won't say vague, but general minimum requirements. For example, one of the requirements is that you must have an authentication system for a covered entity in order to access electronic PHI. So a hospital must have an authentication system for authorized employees to access their electronic health record system. And this is most commonly done using passwords. So the whole password component, that would be part of what we call administrative guidance. So they just set the general rule, like what you must have, but they give guidance on how you can implement. And the reason for that is because we're dealing with technology that's constantly evolving, and the security rule wants to make sure that there's enough leeway to keep up with technology as it continues to advance, instead of setting strict. The privacy rule sets strict standards, like this is how you protect confidential information, and this is just the set of rules you must follow in order to do so. Security rule says, yes, you must protect electronic health information. Here are a minimum set of general standards that you must adhere to do so. So the security rule, by its nature, is OCR's highest enforcement priority. And violations of the security rule are penalized with civil monetary penalties. And those are determined by the size of the and the gravity of the violation. Privacy rule violations they're very rarely penalized with CMPs unless it's a covered entity that's a serial offender. They constantly violate privacy rules. But still, those CMPs, civil monetary penalties, will not amount to as much as what you'll see with the security rule. And there's a few reasons for that. So the security rule violations have the potential to cause way more harm than privacy rule violations. And it's due to, one, the number of victims affected. So for example, there's a breach of a hospital's EMR system. You have a ton of patients' PHI in there, and this PHI, because not only does it contain their health information, but individually identifiable information: name, date of birth, address, email address, phone number, a lot of instances, social security numbers. And that's what comes down to the second part, is the sensitivity of that information. Violations occur when covered entities fail to implement the security rules, security standards, and/or when they fail to maintain compliance. So even if you implement a security rule standard, security rule standard to protect your system, if you don't perform maintenance on it, that could be considered failure to comply as well. And this is regardless of whether or not there's a disclosure of PHI, of course. So even if there's an unauthorized disclosure of PHI, or someone accesses the EHR, whether or not someone accesses the EHR, there is still a violation. But I'll get into like what can be considered mitigating, and then factors that would be mitigating and increases severity. But first, I have this example here on the left for a home health provider. They were required to pay $240,000 in civil monetary penalties for HIPAA violations, and that was due to the unauthorized disclosure of protected health information for about 300 patients. And that's just 300 patients. So if you think about it, that could be maybe like a medium-sized community hospital, not even an academic medical center. So when you're talking about a major institution, you can only imagine the amount of the civil monetary penalties for more patients whose PHI had been disclosed without authorization. So now I'll talk about some factors here that affect the severity of CMPs, civil monetary penalties. And OCR has discretion when there's a violation in terms of how harsh the CMPs are, whether or not you get a slap on the wrist if it's really a very minor violation that didn't result in any unauthorized disclosure. But here are the general factors. The first three would increase severity of civil monetary penalties. Again, number of victims affected, and the severity of the harm incurred. So the severity of the harm incurred can mean like there were every patient that there was whose information was disclosed had social security numbers and addresses. The more sensitive information that was in there would increase the severity. So if you have enough identifiable information that you could commit identity theft, if a bad actor obtained that information, that's increasing the severity of the harm incurred. And then here's the C's intent. And I say purposeful versus negligent. And when I say use the term purposeful, I don't mean that they're really like, it's a malicious, they really want to, stick it to their patients for some reason, which doesn't happen. Purposeful, what I mean here is that when implementing a certain or series of security rule measures that would cost, that would have a high cost to them, they determine that based on their budget or whatever, or whether or not, or based on their the cash flow, it was too expensive to implement a security measure using software that was HIPAA compliant. It might have been too expensive, so they cut corners and they used certain software or security measures that were subpar, that did not meet the minimum security standards set forth by the HIPAA security rule. And then negligence. Negligence here means like it was the covered entity made a good faith effort to comply, but just by by some slip or mishap happened to fail to implement a certain security rule measure, most likely a minor one. And it was not due to purpose intent. And the facts of the scenario would dictate that, and that's how OCR would make that determination. So what would be mitigating is that the covered entity makes good faith efforts to mitigate the harm that had resulted. So they see, okay, data breach to our EMR system, 1,000 patients, PHI was compromised. Immediately notify the patients, provide them with 3 years of free identity theft monitoring, and then immediately contact OCR. And then also when the covered entity proactively engages with OCR and cooperates with their guidance and directives in order to become compliant with the violated regulations, OCR could take that into consideration when determining the level, the severity of the CMPs and the type of corrective guidance and directives that they issue, the corrective measures that they provide in order for the CE to become compliant. And OCR has discretion in these last two areas. And here, the final slide, I just provide a sample scenario. A hospital has a data breach of its EMR system and compromises its patient's PHI. When the breach occurred, the hospital was not in compliance with the security rule requirement for implementing authentication measures, which were commonly passwords, for accessing the EMR system. So I said, let's explore two different causes of this unauthorized disclosure, but I'm going to go with one, and then I'll show you as we progress through this scenario how it could, the outcome could differ. So say that they had the data breach, and it was due to an outside malicious actor accessing their network from outside of this, like somewhere else, not within the hospital's network. They hacked into it. So the hospital would still be liable for CMPs regardless of whether the security rule violation contributed to the unauthorized disclosure. So in that scenario, when the hospital's EMR was hacked, it wasn't due to the fact that they didn't have a password policy in place for employees to access the computer networks inside their healthcare system. They're still liable, but the fact that it wasn't a result, it was directly a result of the unauthorized disclosure could be viewed as a mitigating a factor. So again, OCR has discretion in this case. So in contrast, if someone entered the hospital, say a former disgruntled employee, went in and then they accessed the EMR to try to get someone's, PHI or certain information about them, like their address or something, and that would be an unauthorized disclosure of PHI violating the security rule, and they could get it into the system because there wasn't a password, requirement set in place. They could just hop on a computer and get to the EMR. That violation would be a direct result of their failure to implement that authentication measure, and then that would increase the severity of the CMPs because it was a direct result of the failure of the hospital to implement those security rule measures. So that is my last slide here, and then I have time set aside for any questions that anyone may have. You can either type in the chat, or you can ask unmute and ask.
Hi, Michael.
Hi, Michael.
This is Sad. I have a few questions.
Sure.
So can you please talk a little, first of all, this was very, very helpful. Thank you for the session. We are a consumer app for mental health, for anxiety management. How do some of these things translate into a situation like ours, where we have subscribers who subscribe to a service and get help with their anxiety on our app?
So first, I just want to make sure, make a general disclaimer that any information I provide would not constitute legal advice, but I
Sure.
can certainly give you guidance. So in terms of your app, so you have consumers, and it has to do with is it like a do they connect with a therapist, or how is the information being transmitted?
Sure. Happy to provide specifics, but I totally understand the disclaimer. Trust me, we are a very early stage company here. I'm not trying to get legal advice here, but given your depth of understanding, we are a fully automated service. There is no, therapist involved. It's consumers download the app from the App Store. And we actually have built a real-time tracking technology to track their mental health in real time using the vitals from their smartwatch. So we know throughout the day when they're anxious, when they're calm. And then we provide them insights. The AI goes through their patterns of anxiety and provides them insights about what in their life is making them anxious or calm, so they can modulate their life accordingly. And what we have done is we have made sure that we do have PHI, but only one person in the company, our backend engineer, knows that which user ID corresponds to which email address or name. Otherwise, the data is totally anonymized. So even when I look at our analytics data on, let's say, an analytics platform like Mixpanel, I don't know who I am looking at. I know a user, with ID 7856, has this kind of usage of the app. And the third parties we use for this data transfer, they're all HIPAA compliant. So our data sits on Amazon AWS servers. A third-party analytics platform, Mixpanel, we use is also HIPAA compliant. So I'm just trying to figure out, what is our exposure here, if any, and what are kind of things we should be, be doing differently.
Sure. So one thing I want to just address is, regardless of whether or not you're dealing with PHI, it's always a good idea to use HIPAA compliant software just to protect yourself. The HIPAA compliant apps and what have you. So just to back up, when you say PHI, how is that PHI obtained? Is it is someone in your organization making a diagnosis, or is this information being is it being given by the patients or the users themselves? How is the PHI generated, or
well, sure. So PHI is generated when I download the app on the Apple App Store, right? And I subscribe to the service. Then Apple will associate an ID about this person, which will come to our database. And if the user has agreed to share their name and then, let's say, their gender, right, their age, then we will know user ID, 1234 is a male, right, of this age. But then that information is only accessible to one person in the company, the backend lead engineer. That is, hidden before that information goes to third-party software which other people in the company use. So for example, an analytics platform, Mixpanel, we use that to see how many people we have, what kind of features are they using in the app. We don't know who the person is. We just know, somebody's using in a certain way.
Well, I could tell you right off the bat right now that I would still use HIPAA compliant, be HIPAA compliant, but that actually is not PHI. We'll, in our next talk, we'll get to what that type of health information is, and that's regulated under the FTC's health breach notification rule. And the reason that it's not PHI is because it's not being produced by a covered entity. You're not a covered entity, so that's not PHI. I know a lot of these apps, like when they see health information and stuff like that, they automatically just like treat it as PHI, which is good, like as a safeguard, because HIPAA's security measures are the strongest of any type of health data regulations that, any regulations that have to do with health data. But I can tell you that because you're not a covered entity.
Why are we not a covered entity? I'm curious, because we are doing a diagnosis, clinical grade diagnosis of people's anxiety.
Are you, is there a board certified professional or health practitioner that's doing that?
No, this is real time. So we are looking at their vitals, which we are collecting through their smartwatch. And based on their heart rate variation, there is a proven protocol when a person gets anxious based on what's happening to your heart rate. The heart rate jumps by a certain amount within a certain period of time. And we track that, and we have filed patents on the technology, but we know in real time throughout your day, if you're wearing a watch, when you're anxious, when you're calm. So we have this information, which is very sensitive. We take data privacy very, very, seriously, because this will kill our business if people think that we are not protecting their mental health data. We have like over 800,000 hours of people's mental health data at this point.
Yes,
So-
and there's also the thing about mental health is there is caveats for that. Psychotherapy notes, so it gets a little different when we talk about mental health, but anything in terms of mental health treatment that involves like vitals and stuff, that would be, and medications and diagnoses, that would be PHI if it was, the diagnosis was made by a healthcare practitioner. And then there was a electronic transaction that occurred for the in exchange for the production, for providing that service. But
We don't have a practitioner. Yeah.
I would
Mike,
still treat it as PHI, based on that, the sensitivity of it. Oh, go ahead.
Sab, so if the software, this is the part of the regulation I'm more familiar with. If the software is making a diagnosis on its own, the exact management of PHI is less addressed under HIPAA and more addressed under the Food and Drug Administration, where the software is considered a medical device, or SAMD, software is medical device, and there's an associated cybersecurity rule around that, which will probably be like in the 4th or 5th installment of this series once we have time to produce it.
Got it. Okay. Yeah. Thank you. I appreciated that. Yeah. But we have no doctor looking at this, and we are not prescribing medication. Our interventions are drug-free, breathing, meditation, and these kind of things. So okay.
So
thank you.
We'd be happy to follow up directly to chat about it, and then keep an eye out for the future presentations, because we're going to try and. One of the problems with HIPAA is it's actually remarkably narrow, so it's misapplied. Like we saw that during COVID quite a bit. But for builders of technology, there are relevant regulations under FTC and FDA. So we're going to try and round out that worldview so that folks like you can navigate deftly to the different levels of burden, essentially, around this.
Yeah,
Thank
the
you.
next
Thank you for the question.
Oh, I'm sorry, Ryan. The next lecture will discuss the FTC regulation. That's one that would be relevant to you as well. So there'll be a HIPAA or not a HIPAA, I'm sorry, an FDA reg, and then the FTC health breach notification rule, which basically, as a very brief summary, is that if there is a breach of the data, it specifies like when you must notify the public or notify the FTC about it. So it's not setting, it's not requiring a set of standards you have to implement. But what you're doing by treating it as PHI, your information, that's what I would call best practice, and there's no reason to just continue doing it. That's a great way to do it.
Hey, Mike, thank you, Sab. So we have another question from Russell.
Sure.
So
hello.
Yeah, do you want to, in your own words, Russell, you want to go for it?
I guess I have two questions. I'll start with a simple one. Do BAAs have to disclose to CEs when they have subcontractors? So BAA goes to another BAA or business associate. A BA goes to another BA. Does the CE have to know about that?
Well, that's a good question. So the way it would work usually is first the CE enters a BAA with, we'll say, BA1. So there's a business associate business associate agreement between them. And then say,
Yeah.
well, I mean, the way it would work is that the CE knows like what type of service they need to have carried out for them, and they have identify a firm like this is a good firm. We want them to do that, but
Yes.
they don't have all the capabilities. So that would be a three-way BAA.
Okay.
Yeah.
What if I'll give you a more concrete example? Like
Okay.
we're a TPA, and so we're not a covered entity. We're a business associate of the self-employed or self-insured employers that we work with, but we don't want to have to do, we want to choose our own vendors without, having to pass everything through the employers that we work with. And I'm just kind of wondering what the mechanics of that looks like, because these new vendors might be added in and subtracted kind of without knowledge from the CE, the covered entity.
Yeah, so the covered entity, like in that original business associate agreement between you and the covered entity, it carves out specifically it carves out the scope of exactly which PHI you're receiving from the covered entity. So that's only the amount of PHI you have is what was given to you by that covered entity. And then, so once that agreement goes into effect, you're liable. You're for protecting that information, scope of information for that for that CE. Say you need to so you have a subset of PHI from the CE. They have it all. You have a subset, and then say you need a subcontractor business associate B2. Would you be giving them access to all the information that you have, or just some of it?
Probably just some of it. Like I could see a scenario where we want to use a firm to help us, evaluate whether we're paying the right amounts, or like for various care, or like do some network analysis based on specific claims data. So that's the kind of thing where, as a BA, we would contract with another BA to ship that data back and forth. And that would probably just happen without the covered entity knowing about it, which feels kind of weird. But
yeah, I'd have to clarify that, but I don't think that you need to notify the covered entity about that, because once you have that original agreement with the covered entity, like that information that you have, like you're responsible for.
Yeah.
So whoever you have to go into like subcontractor associate agreements with, you do on your own accord, and you're doing that and you're doing that in order to fulfill the function that the covered entity has contracted you to do. So as long as in that original business associate agreement with the covered entity, it specifies like what functions or what services you'll be performing for them, as long as those subcontractor business associates that you're entering into a relationship with are doing functions to help that are part of
part of our original scope. Okay, no, that's helpful. That makes sense. My next question is just kind of around what identifiable means within HIPAA. Like I know that you can't sell, HIPAA only protects kind of like personally identifiable information, but there are many companies out there that sell kind of aggregated information, including about very small groups. And I'm just kind of wondering what the legislation or guidelines around that is, especially with kind of the rise of like kind of creepy underwriting tools like Milliman Curve, Verikai, Gradient RX, that will basically, underwrite a group of individuals without their consent, but get around HIPAA by, having that be a group. So not sure if you're familiar with that, but I'm kind of curious what the guidelines there are.
So here's the thing. Sorry if I didn't make this clear enough, and this graphic may be misleading because this is only half of it. What PHI is, so HIPAA, regulates PHI, and there's two aspects of it that must be together. First is the health information, and that goes back to the very first slide. General definition of health information is it's like what health info you get when you're at the diagnoses and treatments and stuff. That health information combined like in the same document or the same file electronically with identifiable information, once those two are combined together or are together, that's when it becomes PHI. So HIPAA doesn't regulate just names, dates of birth, MRNs, and stuff like that.
Yeah, it just regulates the connecting part.
Yeah.
But it also like I mean, there are companies where if you give them a number of names, like 10 names or something of specific people, they can tell you medical information about those 10 people without getting consent. And I think like this is like a weird loophole kind of within HIPAA that many people don't know about. And I'm just wondering like how OCR sees that sort of thing.
So are you saying like these companies, they get a list of people? Do they already have like health records?
Yeah. There are companies like, like Datavant links all these connections between PHI databases, and then like you can buy subsets of like identified data as long as you buy them in like a great enough quantity where the view is that, oh, okay, I'm not buying information about you specifically, I'm buying information about you and everyone that works at your company. And so I'm getting a statistic about a group and it's not covered by HIPAA. And this kind of thing exists with like with several companies that have kind of sprung up recently. And I'm just wondering like what OCR thinks about that.
So the information that those companies have that with the health that already have that health information, did they produce it? Were they?
Sometimes they produce it. Sometimes they just license it. Yes. But
I would imagine.
Yeah.
Oh, go ahead. Sorry.
No.
Yeah, I think Datavant and Ciox, had the merger, and I think they are looking at producing a master data management record with some sort of granular consent safeguard, Russell, that would allow you as the consumer of that data to be able to differentiate which people you do and do not have access to. But I'm not particularly familiar with it. But what is the process? RX histories of this? How do you de-identify it?
I mean, Datavant has some white papers about how they do it. I find it kind of fascinating. They basically take the PHI categories, they create a hash, and that hash is going to be unique among like one provider that has some subcategories of this PHI and another provider that has a different category of the PHI. So it'll be able to link like records from the same person, even if you don't have a complete set of the 17 categories of PHI or whatever. And then they like create technology systems where they can operate on this encrypted data and license it in an encrypted form, from what I understand. I don't understand it completely, but I find it like it's used a lot in certain parts of the self-funded underwriting world, and I just didn't know how HIPAA regulators thought about it.
My understanding with Datavant though is that they're BAs with all of those covered entities, and then you're a BA if you're buying that, correct?
That is probably true. Yeah.
Yeah, I think I'm 95% certain that that's the case.
Well, I think they're BAAs with companies, like they could be a BAA with a pharmacy network that manages prescriptions for a large employer or something. But then they could go and sell anonymized views of that data without the employer knowing that their employees' anonymized profiles are being sold. So I'm just like, I'm curious about the sale of anonymized data when it's not that anonymized, and like, what's the limit of anonymization?
I would say that the federal government's delays are not the federal government's denials, as Theranos and a lot of people have discovered, and our personal view around this. So we didn't talk about standard care very much, but we've been building technology around this, and I think the differentiator, frankly, is values. If I'm open with you, so I think, depending on whom you are or what your values are, I think and this is my bias, is the patient ultimately owns their data, and they should have a granular disclosure of which business associates have access to that data, and the ability to revoke it. That currently doesn't exist. And what I would say is Datavant and SciOx have competitors that think it should exist. And the difference is just a matter of values. And I think the federal government's ability, the federal government, Mike can speak to this more, but there's a subtle term, which is enforcement discretion. And the letter of the law for HIPAA is nothing like what we see in the real world. The P is for portability, not privacy. Right?
Yes.
So, but you never get to see it like that. And also there's ability to revoke, which I don't think you could find a single American who's ever revoked their HIPAA access. So that gap between what the law says and what happens is enforcement discretion. And enforcement discretion we'll see kind of like in the individual access laws it's going to play in, and like these FHIR API laws it's going to play in. So it really, what happens in the real world depends a lot on the resources and focus that the government puts into prosecution or investigation and prosecution rather than the law itself. And I think the differentiator is kind of a value system, and it's one of those things where it's like relevant until it's irrelevant until it's not, and then it's like kind of black and white. I think we're on the side of the patient and granular consent, but I think we're in the minority currently.
Cool.
Right.
Thank you.
Yeah,
That's helpful, Russell.
thanks, Russell.
Question.
Excellent question.
Yeah, that's cool.
All right, we didn't get to say thanks before people started dropping off, but hopefully this is a delightful week for everybody going into the holiday, and this was a kind of a relaxing, informational way to spend time. Special thanks to Michael. He put a ton of work into this presentation. Getting the details of this right is not trivial. He wants to make sure he's doing right by you on every word, every letter, and I think he did an excellent job. So thank you, Michael. And keep an eye out. We're going to follow up with an email with a link to the recording, and then another registration links for the next event. And we're honored to have you. Thank you so much for being here.
Thanks, everyone.
See ya.